Welcome back, everyone. You're tuning in to part 9 of our masterclass series, and today we're tackling a massive topic that absolutely trips up even the most seasoned medical coders out there. We're going to completely demystify the 2023 and beyond evaluation and management, time-based coding guidelines, and we're going to decode the real complexities of prolonged services. So if you've ever felt like you literally need a math degree just to bill a patient visit, or you found yourself scratching your head over Medicare versus commercial rules, well, you're in exactly the right place. Let's dive in. Here's our roadmap for today's explainer. 1. Defining total encounter time. 2. Countable versus non-countable activities. 3. E&M time threshold rules. 4. Prolonged services add-on codes. 5. Medicare rules and G2212. And 6. Documentation best practices. All right, Section 1, defining total encounter time, shifting the paradigm. To really understand time-based coding today, we have to acknowledge a fundamental shift in how time is actually defined. Back in the day, time-based coding was heavily focused on just the face-to-face time you spent counseling the patient. But honestly, that's old news. The critical shift for 2023 and beyond is this concept of total time. Now, total time includes both face-to-face and non-face-to-face time. But here's the catch, and it's a big one. It must be time personally spent by the physician or the QHP entirely on the exact calendar date of the encounter. Picture Dr. Smith reviewing patient labs at 11 p.m. the night before a visit. Unfortunately, that time, it doesn't count for today's encounter bucket. It's all about that specific calendar date. Moving on to Section 2, countable versus non-countable activities, what actually counts? If we're looking at total time on a specific date, we need to know exactly what goes into that bucket, right? What's really interesting here is just how much behind-the-scenes work is finally getting recognized. Your countable time includes preparing to see the patient, like reviewing their past tests. It includes obtaining and reviewing history, performing the exam, and counseling the patient or their family. But it also includes ordering tests and meds, EMR documentation, care coordination, and independently interpreting test results, as long as you aren't billing a separate CPT code for that interpretation, of course. This is your day-to-day clinical reality, and as long as it happens on the day of the encounter, it successfully builds up your total time. But we've got to draw a hard line to stay audit-proof. Allowable activities are your green lights, but the strict exclusions, those are your red lights. You absolutely cannot count clinical staff time. If your medical assistant is rooming the patient, that is not provider time. You cannot count travel time or general teaching that isn't specifically for the management of this particular patient. And crucially, if you're performing a separately billable procedure, like maybe an EKG or a minor surgery, that time is completely walled off and excluded from your E&M bucket. Which brings us to Section 3, EM time threshold rules, hitting the mark. Let's move to the math portion of our masterclass and see how these allowable activities actually add up to meet your specific code levels. Looking at the office and outpatient thresholds, it's literally a ladder. For an established patient, you hit level 2 at 10 minutes, level 3 at 20, level 4 at 30, and you finally unlock that level 5, the 99215, at 40 minutes. The golden rule here is met or exceeded. Think about it. If you spend 39 minutes, you are locked into a 99214. No exceptions. You must hit that 40-minute finish line to cross over to the 99215. And here's the beautiful part. This met or exceeded threshold logic, it isn't just for the outpatient clinic. Whether you're coding office visits or inpatient and observation care, the fundamental rule remains exactly the same. You just find the total countable time on the date of the encounter and match it to the threshold it meets or exceeds for that specific code set. Simple as that. Section 4, Prolonged Services Add-on Codes, going beyond the max. So what happens when you have a highly complex patient and your encounter time goes way, way beyond the highest level code limit? 15. That is your magic number. Prolonged services codes don't just trigger for a few extra minutes here or there. They operate strictly on 15-minute increments beyond the required time of the primary service. You can't bill for half of a prolonged service. You've got to hit that full 15-minute block. For instance, check out CPT 99417. This is your add-on code for prolonged outpatient evaluation and management services. It triggers for each full 15 minutes of total time beyond the required time of the primary service, meaning it attaches to your level 5 visits, like a 99215 or 99205. And just a quick note, if you're in the hospital setting, CPT 99418 functions the exact same way for inpatient and observation prolonged time. All right, on to Section 5, Medicare Rules and G2212, the plot twist. Just when you think you've got all the rules down, we have to introduce a massive compliance warning. There is a huge discrepancy between AMA, CPT guidelines, and CMS Medicare rules. For commercial payers using AMA guidelines, you report CPT 99417 when you hit 15 minutes beyond the minimum time required for that highest level base code. But Medicare uses their own HCPCS code, G2212. And Medicare says no, the prolonged threshold doesn't start until you exceed the absolute maximum time of the base code's time range. Okay, let's break this math down step by step so it's crystal clear. Step 1. Look at an established patient, level 5, code 99215. The time range is 40 to 54 minutes. Step 2. Under Medicare rules, your prolonged clock doesn't even start ticking until minute 55. Step 3. You report G2212 for a full 15 minutes beyond that 54-minute max. So to actually bill just 1 unit of G2212 to Medicare, you need a total time of at least 69 minutes. It's a completely different calculation, and mixing these two up is for sure the fastest way to get a denial for Medicare. Finally, Section 6, Documentation Best Practices, the Golden Rules. This is arguably the most important section for audit survival. Because look, if it isn't documented correctly, it simply didn't happen. Let me hammer this golden rule home. While you aren't strictly required to document exact start and stop times, like started at 2 p.m., ended at 2:40 p.m., you absolutely must document a single specific total time. Vague statements like spent 15 to 30 minutes are an instant failure in an audit. You need to confidently write exactly what you did, something like, I spent a total of 45 minutes on the date of the encounter. Time is literally ticking on your charts, folks. If your documented time is less than the minimum required for the code you want, or if you just forget to document the time entirely, you lose the ability to bill based on time, period. At that point, you're forced to fall back and level the visit based purely on the complexity of your medical decision-making, your MDM. And that might result in a lower level of service, leaving rightfully earned revenue on the table simply because you forgot to write down one number. So I'm going to leave you with this question for your very next chart. Are your time entries reflecting the hard work you actually did? Or are you just gift-wrapping an easy refund for an auditor? Keep your documentation precise, remember that Medicare math, and you'll navigate this landscape with total confidence. Don't forget to like, share, and subscribe to Decode Healthcare with Harshal.